Good afternoon, everybody. Welcome to the webinar. Today, we are taking a dive into cardiovascular disease and sleep disorders. I am going to give everybody a moment to jump on. I see everybody coming in, and then we're going to go ahead and get started. If you want to move to the next slide, we will go through just some notes to make your webinar a little more enjoyable. All attendees are in listen-only mode. So if you can't hear, hopefully you can read the slide. Check the audio button on your personal computer to assure your sound is on. That's usually the issue that people experience. Please type any of your questions into the Q&A at any time during the presentation, and the moderator, which is me, will read your questions out loud during the Q&A period. A PDF version of the slides, as well as a recording of the presentation, will be available on the Mended Hearts website. And we will have all of the handouts available on the handout section of the website as well. Go ahead and advance. So before we get started, if you're new to Mended Hearts, our mission is to inspire hope and improve the quality of life for patients and their families through ongoing peer-to-peer support, education, and advocacy. You'll see on the next slide that I am Andrea Baer, the Executive Director here at Mended Hearts, and we're very, very happy to welcome Dr. Michael Grandner with us today. He is a licensed clinical psychologist, and I am going to let him introduce the rest and get started. So thank you so much for being here with us today.
All right, yeah, good morning. So a little bit about me. I'm a sleep person. I'm a psychologist by training, board certified in behavioral sleep medicine. I run a clinic here, and I also direct the sleep and health research program here at the University of Arizona. I've been involved in sleep research for a very long time, and one of the areas that I focus on is the overlap between sleep and heart health. And because my research is all about how does sleep impact people in the real world, in conditions that they actually care about. And so that's where I got into study heart health. So I'm going to be talking a little bit about sleep and cardiometabolic health, just some basics, and then open the floor up. But I want to start here, that sleep is a non-negotiable biological state required for the maintenance of human life. Our need for sleep parallels that for air, food, and water. This is important to know, that sleep isn't just something we all coincidentally kind of like to do. It's not. Why do we sleep? We sleep because we have to. Sleep is a foundation of our biology. I encourage everyone who has access to check out the special issue of Science that came out. This is a quote from the paper that I contributed, really just sort of overviewing why sleep is important and how it can sort of direct science in the next generation. But sleep is foundational to our biology. It touches all kinds of things, including heart health. However, we live in a society that often sees sleep as an unproductive use of time. And there is nothing more un-American than an unproductive use of time. And that creates problems. In particular, it creates societal pressures that devalue sleep. So I love finding sleep images online. Here's one. It says, let's stay up unreasonably late tonight and then complain about how unreasonably exhausted we are tomorrow. And look how much fun they're having, not sleeping. I think this is illustrative. And it also has that other side of the coin that we're starting to recognize that, well, okay, maybe our sleep is tied to our functioning, but we're still choosing to devalue sleep anyway. But even still, we're starting to recognize that, maybe we should be taking sleep a little more seriously because, it is foundational to our biology and all. It is a problem. About 30% of the US population isn't getting the recommended 7 to 8 hours of sleep. And the issue is, that category of 6 hours and less is associated with impaired performance, obesity, hypertension, diabetes, poor mental health, inflammation, and mortality. And people die sooner in that category, also the long sleepers. I'm not going to have time to go through every single one of these and why, but part of the reason is that sleep is related to multidimensional health. Sleep is related to metabolic health, cardiovascular health, immunologic health, mental health, behavioral health, and cognitive health. All of these things are related to sleep. And the way I draw this is that these are separate boxes, but they're all within a larger field. You don't see the arrows pointing from one to the other, to the other, to the other, because all you would have is just a big old mess of spaghetti arrows everywhere, because all of these things are related to each other. And sleep is upstream of a lot of them. So here's an example. Here's data from a few 100,000 people across the US saying, okay, how much you sleep, how is that tied, how is that related to whether or not you're obese, have high blood pressure, diabetes? So on the left, you can see that the very short sleepers, these are people getting less than 5 hours a night. Men are 35% more likely to also be obese. Women are about 58% more likely to also be obese. And let's say you're just a short sleeper, 5 to 6 hours. Well, you're still about 30 to 34% more likely to be obese than someone who's a 7 to 8 hour sleeper. And even the long sleepers, especially women, are more likely to be obese than 7 to 8 hour sleepers. Look at high blood pressure. Again, the very short sleepers, you're almost doubling your likelihood of having hypertension. Even if you're getting 5 or 6 hours, that you're still about 30% more likely to have high blood pressure. And even long sleep, you see this elevated risk as well. And then if you look at diabetes, similarly, the very short sleepers are much more likely to have diabetes. The short sleepers are also more likely to have diabetes. And the long sleepers are even more so than the other conditions more likely to have diabetes. There's even more of a mechanistic link with excess sleep and diabetes risk. But this is just an overlap. You know, what if it's the case that maybe it's not that lack of sleep is leading to these things? Maybe it's just like if you're obese and have hypertension, you have poor health and you're more uncomfortable and you're not sleeping as much, or you're more stressed. I don't know. So then you look at incidence studies where they track people over time, where people start out without these conditions and then they see who develops them. So here's the data from a meta-analysis looking at obesity, where these are all studies where people started out not obese and they track them over time. And they see, are they more likely to become obese over time? And what you can see here is that people who are short sleepers are 55% more likely to become obese than people who are 7 to 8 hour sleepers. Here's the data for hypertension across a bunch of studies where they track people over time. People who did not have hypertension at the start, did they end up getting hypertension? Yes, they were about 20% more likely to develop high blood pressure. And here's a study on diabetes. They were about 30% more likely to develop type 2 diabetes over time compared to people who were not short sleepers. So not getting enough sleep. And the reason why we're looking at amount of sleep, not necessarily sleep disorders here, is because that's what we can measure in these large population studies. We actually don't have good population metrics on a lot of sleep disorders. We have some estimates, but they're not as good as we have for amount of sleep. And so that sometimes becomes a proxy for whether your sleep is good or not. And that's just obesity, hypertension, diabetes. You can see this across the board and lots of other things too. But this is complicated, because sleep is dynamic. It changes with age. So one thing that nobody over age 30 is going to be surprised to see is that as you get older, your sleep becomes more shallow. So this is a measure of sleep efficiency. You see age across the bottom. You see percentage across the top. Sleep efficiency is a marker of how much of the time that you spent in bed was actually spent to sleep. So people with lower sleep efficiency are laying in bed more awake, they wake up more during the night, et cetera. And what you can see here is as we get older, sleep efficiency starts dropping. And people, as they get older, they wake up more during the night, maybe takes them a little longer to fall asleep, their sleep's a little more shallow. All right. But what's interesting is, if you ask people, how distressing is your sleep? How much of a problem is your sleep? Actually, it goes in the opposite direction. So here's some data. The y-axis here is how many excess nights per week are you not getting enough sleep? Chart that out by age, you actually see it's the 20-year-olds who are reporting the most insufficient sleep, and the older adults, once they retire, they're reporting that they're not getting insufficient sleep. We've seen the same curve for sleep disturbance. We see the same curve for fatigue. We see the same curve for sleep debt. The perceived problem of sleep actually goes down with age, which sounds extremely counterintuitive, but we see it in like every population metric we look at. It's not that they're waking up less, it's that it's impacting them a little less. And this relates to cardiometabolic disease risk. So we looked at the three-way relationship between amount of sleep and body mass index and how that relationship changes with age, controlling for all of these other things. And what you can see here is, if you want to sort of chart that out, imagine this curve and imagine how the line changes across sort of each age group. Now, the cool thing about this figure is that it's like in color and very sciencey, but it is kind of hard to read. So we broke it up into these four groups: the very short sleepers, the 7 to 8 hour, the standard sleepers, and then long sleepers. And what you can see is in the young people, more sleep is better. Younger people need more sleep. So the longest sleepers have the lowest body mass index, and the very short sleepers have the highest body mass index. And then what you see is, as you get older, the benefits of extra sleep go away, and you start getting this U-shaped relationship that emerges, where both long and short sleep are associated with more weight, where the 7 to 8 hour becomes optimal. But then once you hit around age 65, these groups all start collapsing on each other, and the effects sort of go away. And we see this in a bunch of other things too. So here's another example of hypertension. So here's data from about 750,000 people recorded over about 10 years, cross-sectional relationship between how much you're sleeping and whether you have high blood pressure. I'm not even putting in the odds ratios here, just putting in the p-value. And where is the p-value super robust? And you can see, pretty much all these age groups, shorter sleep is associated with hypertension. In the youngest people who have very little hypertension, actually you see no problems with longer sleep, and actually 6 hours is probably okay. But this is where you start getting into risk until you hit about age 70, and only the very, very extreme short sleepers are actually having elevated hypertension risk. And well, same thing. So as you get older, the relationship between how you're sleeping right now and heart health actually gets a little weaker. So we have to focus on the younger people a little more. You see this in other things too. We have data showing that the same thing happens in cognitive decline, that as you get older, the relationship with sleep gets weaker. We see this across the board, and it makes sense. So because as you get older, you're at risk for all kinds of other things. How you slept for the past couple of weeks, if you're an obese 70-year-old, if you have high blood pressure at age 70, how you're sleeping right now is less important to that question than maybe how you've slept for the past 20 years. That might actually be what's contributing to your health issue, not just what's going on right now. Only to the degree of what's going on right now is indicative of how it used to be. So, and you have other competing things going on too, and other risk factors, but this is just showing this is actually some good news with aging, that the relationship to current sleep actually sort of gets weaker. So, but why are these things connected? So one pathway is through insulin and glucose. So this was a very classic study that was done 20 years ago, spawned a whole field where they had either 12 or 4 hours time in bed. And what you see is, compared to when you compare the two conditions, that you have impaired insulin function, impaired glucose function, and more insulin resistance. Just a short-term sleep deprivation, and then they let them sleep for a couple of days and they went back to normal. But right away, it's throwing off metabolism. And this has been replicated a ton of times. This is sort of why you get this elevation of diabetes. Leptin and ghrelin, looking at metabolic hormones, where leptin helps you feel full, ghrelin makes you hungry. To summarize it in 5 seconds, obviously, yes, it's more complicated than that. But again, another classic study where these findings have been replicated a bunch of times in the laboratory, where sleep deprivation decreases leptin and increases ghrelin across the whole day. And so you're maybe more likely to be hungry and less likely to be full. And what this means, and so what was interesting is, in the discussion section of this paper, they said, if we look at these hunger and appetite ratings, we'd guess that people would start consuming 350 to 500 extra calories a day if this was true. So remember that number, because a bunch of years later, they were followed up within laboratory studies where they sleep-deprived people and then looked to see how they ate differently. And what you can see here is 5 versus 9 hours. What you see is you have slightly less intake at breakfast, in the sleep deprived group, but you have this huge increase in intake of food after dinner. So this is late night eating. When you keep people up, when people are sleep deprived, they get extra hungry, especially at night. And maybe because they ate so much at night, they're eating less at breakfast the next morning because they're still full. This has been replicated a bunch of times. My favorite study that did this was about 200 people sleep deprived versus 27 controls. They simulated a 5-night sleep deprived work week. So they were restricted to 4 hours for 5 nights in a row, had unlimited access to food. And what you saw was the people who had no sleep restriction, their weight didn't change in a week. But the people who were sleep restricted, they gained about 1 kilogram, about 2 pounds they gained in just a week. And actually, who you were dictated this. So women gained less weight than men. And this is Philadelphia, so it was very black and white. So if you were black, you gained more weight than if you were white. So black men gained the most weight, white women gained the least amount of weight. Why? Still sort of exploring what's going on here. But again, if you look at the timing of the food consumption, slightly less food at breakfast, no difference in the middle of the day. After 10 p.m., notice there's 1 bar here because the other group was asleep. And so when they kept up, they ate an extra 500 or so calories. And this is what you see over and over and over again. People are eating an extra 400 to 500 calories, especially at night when they're sleep deprived. Inflammation. So systemic inflammation is a key mechanism for cardiometabolic disease, and sleep deprivation is, this is a reason why you're supposed to rest and sleep when you're sick, because sleep impacts the immune system. But lack of sleep is a pro-inflammatory state. So this is some data we published looking at nationally representative data showing this U-shaped relationship between how much you're sleeping and your baseline levels of C-reactive protein, even after adjusting for all the other things that should be elevating it. And you can see this over and over again, that lack of sleep and also excessive sleep of sleeping 9, 10, 11 hours associated with poor inflammation. So in terms of general health, so the American Heart Association, their official definition of cardiovascular health is the Life Simple 7. And the Simple 7 are the 7 components that are associated with heart health, which was blood pressure, cholesterol, fasting glucose, diet, obesity, physical activity, and smoking. And so what we did in this study, we looked at overall global health in a nationally representative sample and said, how much do these things correlate with just global health on their own, and then sort of combined as a Life Simple 7 sort of metric. And they each do, like, high calorie diet was, on its own, didn't seem to do a whole lot, surprisingly, but it's because measuring diet on the population level is just super messy anyway. But all of these other ones seemed important. And then we looked at how much you're sleeping. Yes, that was also correlated with overall health pretty strongly. And then we looked to see, does adding sleep to Life Simple 7 give you anything new? And what we found, it did. And so that sleep actually might be a unique contribution here. And other people have agreed. So the American Heart Association actually just this year, just a few months ago, came out with the official redefinition of cardiovascular health. It is no longer Life Simple 7. Now it's Life's Essential 8. First of all, it was never that simple to begin with. And it's the same components, except now sleep is actually one of the primary components of defining cardiovascular health, because just like diet, exercise, lipids, blood pressure, smoking, it's in there as one of the things that's foundational in terms of creating heart health. And I'm putting this other image on here too, showing that you have the Essential 8, but this also exists on a context of psychological health and social determinants of health, like neighborhood and environmental and community and systemic and structural health. All of these things influence the Essential 8, which are the new definition of heart health. So sleep is now part of the official definition of heart health, according to the American Heart Association. It's big news, and I was one of the authors of it, which is why I'm especially excited. But like, this changes everything in terms of how heart health is defined. So part of this other issue, I only talked about sort of the cardiometabolic risk stuff. So sleep loss is related to both poor health, but also impaired brain function. I didn't talk about this. That's a whole other can of worms. That sleep health impairs, poor sleep health impairs brain function. And these might be related things. It's not just that it's both. Remember at the beginning, I said there are those things and they're all related to each other. Well, how is brain health related to metabolism? Well, a lot of health conditions are made worse by increasing stress and greater difficulty making healthy decisions. Why are people eating more at night? Why does nobody crave a salad at 2 o'clock in the morning, but people are eating junk food? So this is where the brain interacts with the cardiometabolic systems in terms of promoting health. And I just wanted to do a quick plug about this study that actually just came out, where we tracked sleep over the last 15 or so years. And what we did note there has been a slight decline in how much people are sleeping in the US. But also this decline is unequally experienced, where this is sort of non-Hispanic whites. And other groups were declining also at about the same rate. But the two groups that are declining faster are Black Americans and Mexican Hispanic Americans. And you can see on the left here the trajectories, where we all have already known that there's disparities in terms of sleep health, where if you're Black in the US, you're less likely to be getting enough sleep. And look, that gap is widening. And actually, it used to be the case that if you were Mexican American in the US, you were more likely to actually get 7 or 8 hours of sleep. But that gap is declining, and actually it's now reached parity, where they're losing sleep at the fastest rate, and so we might have a disparity that's emerging. And on the right, you can see the cause is the sharp increase in short sleepers, people getting 6 hours or less of sleep in the population, disproportionately in those groups. And what I didn't put on here is in this paper, we actually showed population changes in hypertension, prediabetes, and other cardiovascular health outcomes, showing that this change in sleep accounted for part of the variance in the change in those outcome metrics. So this really does matter, even though it's on a population level, it's a few minutes difference from 1 year to the next, but that's adding up in terms of population level cardiometabolic health, and it's disproportionately affecting some of these groups. A little bit about what do we know about some of the other sleep disorders? So in particular, insomnia. Insomnia is difficulty falling asleep or staying asleep, especially if it takes you more than a half an hour to fall asleep and you're up for more than half an hour during the night and it causes daytime impairments. That's insomnia. And so looking at insomnia symptoms, we know people with insomnia symptoms are more likely to be obese, have diabetes, have had a heart attack, have had a stroke, have heart disease. People who have insomnia symptoms are associated with more weight gain and obesity. They're more likely to have trouble losing weight. People who have difficulty falling or staying asleep have 20% more likelihood of hypertension, just like lack of sleep duration. And it's associated with more than a doubling likelihood of having uncontrolled HbA1c as a diabetes risk factor. So yeah, insomnia, inability to sleep, irrespective of how much sleep you're getting, that struggle to sleep is also associated with heart health. There's sleep apnea. Most people know about sleep apnea as a major heart health risk factor. And it's a heart health risk factor for a number of reasons. Sleep apnea, of course, being difficulty breathing during the night. So you have this upper airway obstruction during the night. It leads to things like sleep fragmentation, endocrine dysregulation, persistent respiratory effort, which is also related to stress on the system. You have cortical activation in the brain that creates stress on the system. You have increased sympathetic tone, and you have decreased O2 levels, which lead to elevated oxidative stress. So between the sleep fragmentation, the oxidative stress, the stress on the heart, this is why people with untreated sleep apnea tend to have heart attacks and strokes long earlier than they should have. If they were going to anyway, it's going to happen earlier if they have untreated sleep apnea. It's a major cardiovascular risk factor. A little bit about narcolepsy. A lot of people don't know much about narcolepsy, and what they do know is probably incorrect by what they've seen on TV and movies. So narcolepsy is also associated with cardiovascular risk. Narcolepsy is a condition where sort of the boundaries between states become eroded, where when you're awake, it's hard to stay awake. When you're asleep, it's hard to stay asleep. And when you're asleep, the boundaries between REM and non-REM sleep also become very blurry, where REM starts bleeding into wake, and you have all these sorts of dysfunctions. And So it mentions on here hypocretin deficiency. What that means is that there's a neurotransmitter called hypocretin, or also called orexin, where in narcolepsy, the cells that produce that in the hypothalamus die, and then you don't have that that substance in your brain. That's what leads to all this problem. So it leads to difficulty with nighttime sleep and excessive daytime sleepiness, which has these different impacts. So in terms of cardiometabolic disease, you get increased heart rate, increased blood pressure, you get lack of dipping in blood pressure, and more cardiovascular variability, which leads to more vascular inflammation and endothelial dysfunction. You also get metabolic comorbidities like diabetes, obesity, and dyslipidemia, and systemic inflammation. And all of these things, and you also have the psychiatric and other behavioral risk factors. All of this leads to increased cardiovascular risk, which is why people with narcolepsy are more likely to have risks for things like heart attacks, strokes, heart failure, and other cardiovascular diseases, because of these mostly indirect pathways. By disrupting sleep and by disrupting sleep-wake regulation, you're disrupting all of these things. Another indirect pathway is the narcolepsy medications themselves might be contributing to cardiovascular risk. Part of that has to do with sodium, where sodium oxybate is a well-studied and effective treatment for narcolepsy. It's probably the gold standard, best well-studied, and probably most effective treatment for narcolepsy. However, there's a problem in that, hence the name, it has very high levels of sodium. Sodium intake is associated with higher blood pressure. In particular, it's via increased vascular resistance, increased arterial stiffness, and more fluid retention. So here's an image that sort of maps out some of these pathways, but higher sodium intake eventually gets to higher systolic and either the same or higher diastolic, but it's mostly higher systolic blood pressure associated with higher sodium intake, which leads to more fluid retention and some of these other mechanisms. So this is why people who have high blood pressure should decrease their salt intake, or people with high salt intake have more high blood pressure. So poor sleep health is also associated with higher blood pressure. I talked about this already, including narcolepsy, which I mentioned. And we also do know that in general, reducing salt intake could prevent cardiovascular disease. So I tried to find some of the most recent data on this. This is an excellent study out of Japan that showed how many cases of ischemic heart disease and stroke could have potentially been prevented by reducing salt intake to either 8, 6, or 5 grams per day of sodium. And what you can see here is you have the more you're cutting off salt intake, the more likely you would be to be preventing some of these heart diseases, especially as people are getting into middle age and older. So there's a number of studies showing this, that by reducing salt intake, you could potentially improve long-term cardiovascular health. So that's a particular problem here, and why other treatments that potentially have lower sodium might, if you can match the efficacy in narcolepsy, because narcolepsy itself is bad, so treating it is important. But if you can treat it in a way that doesn't elevate sodium in the same way, you might have improved heart health there. So some take-home points: insufficient sleep is associated with incident and prevalent obesity and other cardiovascular diseases. Pathways include blood pressure, insulin sensitivity, metabolic hormones, inflammation, other unhealthy behaviors, psychosocial stress, and other neurocognitive problems are predisposed to unhealthy eating. Sleep disorders are also associated with cardiometabolic disease, including insomnia, sleep apnea, and narcolepsy. So here's a quick plug for our lab. Here's our website. Here's our trainees and students and our funders. And thank you very much. And I'm open for any questions.
Thank you so much. That was a lot of really great information. So anybody who's listening, if you want to put a question into the Q&A box, I am going to start asking questions now, as is my cat. And Dr. Grandner can answer. So I have a couple of questions here already. One just says, congratulations on your research that sleep is definitely essential. one of the questions is there a relationship between sleep and your daytime fatigue?
Great question. So first of all, fatigue is a complicated word where in my world, fatigue means something very specific, where in the real world it doesn't. Fatigue means I feel crappy during the day or I don't have energy. But there's sleepiness and there's tiredness, where fatigue represents this state where you don't quite have the resources to meet your demands, whether it's energy, whether it's mental space, whatever. You get fatigued, you're like out of gas. Now, the other side of fatigue is sleepiness, where you just can't stay focused, you can't stay awake. For that one, if you know someone who falls asleep, has trouble staying awake when they're trying to stay awake, when they're, worst case driving, but even if it's someone who sits on the couch, can't watch a show without nodding off, that's sleepiness. That's not fatigue. They could also have fatigue. Sleepiness, the primary cause of sleepiness is lack of healthy sleep. Maybe they're getting enough, but it's poor quality because maybe they have untreated sleep apnea or something, or maybe there's some chronic pain and they're not being able to get deep restorative sleep or something like that. So if you know anyone who's having trouble keeping their eyes open or they're like nodding off, that's sleepiness, not fatigue, which is directly related to sleep and very few other things. The only other things that would cause sleepiness during the day, the only other one that's remotely common would be like medications that you're taking during the day that reduce consciousness. Then there's fatigue. So lack of sleep does cause fatigue. Insomnia, even if you're sleeping 7-8 hours, can also cause fatigue. Poor sleep quality, even if you are falling asleep quickly and staying asleep, but it's very shallow because of untreated sleep apnea or something, that also causes fatigue. But other things also cause fatigue too. Things like anxiety and depression, which also does impact sleep, causes fatigue independently of sleep. So I guess the answer is yes, maybe in more ways than most people realize, but not only. There are other causes of fatigue too.
Like children cause fatigue.
Yes. And I should also mention heart failure and heart disease itself, because of the way the heart is, if the heart has trouble functioning properly, you will feel fatigue during the day no matter how you sleep at night, for example.
Thank you. So does using a CPAP increase or decrease your heart's proficiency?
Excellent question. And it's pretty well established that if you have sleep apnea, especially if it's severe, not treating it is associated with a lot of increased risk. The data on treating it and how much that reduces risk is surprisingly spotty, mostly because people hate using their CPAPs. So in all of these large studies, there's so many people in the study who don't use it. Like, what I can tell you is CPAP does not reduce risk if it's just sitting on your nightstand and you're not wearing it. Being next to it doesn't help. Wearing it, I'm comfortable saying that the available evidence strongly suggests that regular use will improve outcomes across the board in cardiometabolic health. The strongest benefits that are observed are in terms of daytime fatigue and sleepiness. There's like a dose response, like per hour of use per night, you have increased energy level and better feeling during the day. Does it prevent heart attacks and strokes? That's hard because you need to study it in large samples, and large samples of people in real world situations, there's an adherence issue. And so in all of those studies, among other issues, in all of those studies, the average use is at most like half the night. And so already it's like, do antihypertensives work when you cut the dose in half? Well, I don't know. Doesn't mean the antihypertensives don't work. So I apologize for rambling about this, but it's a big issue right now in the field where we have a hard time showing the benefits because it's hard to use. But the strongest benefits are in daytime functioning. And that's very clear.
Okay. So the next question, I think you answered, but maybe we can revisit it. Are people with sleep apnea more likely to have serious heart issues then?
Yes, and because I had already talked about the basics, I'll add a couple of caveats. First of all, how severe the sleep apnea is seems to matter a lot. People with relatively mild sleep apnea, where it's only a few events per hour, the data are really murky as to whether that's really dangerous, especially if people are feeling fine during the day. If you're not feeling fine, at least treat it for the symptoms. But in mild sleep apnea, there's a controversy as to whether you actually need to treat it, how much is kind of in the normal range. The other thing is, there's also another controversy around treating it in people who, if your sleep apnea didn't exist before the age of 65, and it's just showing up now, if you're older, and you really don't like CPAP, actually, there's a lot of data that shows that maybe you don't need to be as aggressive treating it if you don't have daytime problems. If you have daytime problems, treat those symptoms. But it looks like the negative effects of sleep apnea are cumulative and take 20 years. And if you're already over 65, 70, there's so many other health issues that you're probably worrying about. Maybe you don't need to have sleep apnea be your primary one if you didn't have it previously. Because if it's just emerging now, it's that definitely talk to your doctor about it, because there's questions there. So it's actually maybe less, just like everything else I showed. As you get older, the risks associated with sleep issues actually start fading. You become more resilient, things like that. So there's some good news, and maybe don't panic.
Great. So is lack of sleep that's caused by medication, does that change your heart risk associated with the lack of sleep, or is it?
It's the same. To my knowledge, to the best of my knowledge, it's the same, and actually may be worse, because a lot of medications that cause sleep disruptions, have other kinds of risks involved too. Especially medications that are stimulating, where they can have they have heart, like even caffeine, has heart-related risks that are totally separate from lack of sleep, with the caveat that caffeine has a little bit of a paradox, where caffeine itself as a drug should be causing more cardiovascular disease, but for some odd reason, coffee drinkers actually tend to have less cardiovascular disease despite the mechanisms. When I talk to a caffeine expert about this, they're like, well, we don't know why, but it's probably because people's primary source of caffeine is coffee. Coffee, being plant-based, has all kinds of other antioxidants in it and other polyphenols and whatever that might actually be beneficial in outweighing any of the negative risks. But that might be why humans just have been doing this for thousands of years and been fine, for whatever that's worth.
So somebody is asking for tips for increasing the quality and the duration of their sleep.
Right. So first of all, in terms of duration, first thing I want to say is, to be able to sleep more, you need to be able to. Some people can't. And so, or at least can't all at once. Sometimes the way to get more sleep is actually to nap. Napping can, especially strategic napping, can be a great way to add sleep without adding more pressure. Some people can't. If you have plenty of time to sleep and you just can't fill that time, giving yourself more time might not be the answer. You might need to move it to sleep in a couple of shifts. That happens sometimes. But also, if you have insomnia, just giving yourself more time is going to work. So actually, maybe fix the insomnia first. And I should mention that the #1 recommended treatment for insomnia, that beats all sleeping pills that are existing on the market in terms of recommended use and safety and long-term efficacy, is actually cognitive behavior therapy for insomnia, CBTI. It requires some special training, but there are ways to, if you go to behavioralsleep.org, Society of Behavioral Sleep Medicine, there's directories of people who do it. It actually treats insomnia without medications and works like 85% of the time. Especially, it even works in people with heart disease and people who are older, people in pain, people with other it still works without the medication side effects. Though most people still just use medications, which are sometimes okay. But in terms of how to get quality sleep, first of all, if you have a sleep disorder, get it treated. If you might have sleep apnea or have an insomnia disorder, not even realize it. All the tips in the world aren't going to fix a medical condition. Just like if you have heart failure, going for a walk and eating heart healthy foods is probably not going to cure your heart failure. Once you reach a certain level, just see a sleep specialist, get it diagnosed and treated. But let's say you don't have a sleep disorder, but still have shallow sleep. I would say the most common causes of poor sleep quality, separate from not getting enough sleep, are in order is number one would be like untreated sleep apnea. It's so common that people don't even know they have it. Number two would be chronic pain. And so managing pain could be one. Another one is environmental, like you have noise, you have a moving spouse, maybe you're a lighter sleeper than you think. And as you get older, you might have more shallow sleep too. You might be more likely to wake up a bunch of times. And then also because you're trying too hard to sleep. No one got to sleep faster by trying harder. You're adding energy into a system that requires decreasing energy to work. So what I would say, if you can't remove some of those barriers, the three things I'd leave people with is number one, make sure you have enough time to sleep. You budget time for it. If you have to get to work and you're like, well, it takes me half an hour to get to work, I'm only going to give myself 15 minutes to get there, you're going to be late. And if it takes you seven-ish hours to get restful sleep, and it takes you 20-something minutes to fall asleep, and you're going to be awake for 15, 20 minutes during the night, and you want to lay in bed for 15 minutes before getting up, you need to budget 8 to get there on time. So like you got to budget for it. You got to plan for it. Think of your sleep as a commute to tomorrow. And so as long as you're setting up enough time, make yourself ready for it. Your brain's not a light switch. You don't go from 30,000 feet to parked at the gate in a flick of a switch. You have to sort of like, now's the time to start powering down the large electronic devices. And then they come in for the landing, and then they taxi, and then they open the door. And that's how your evening has to be. You can't just go from work, busy, distracted to, okay, I'm in bed now. And your brain's like, oh my gosh, hold on. I gotta take this time now. Now we have your attention. Like now we can think about all these things. And that's not where you want it to happen. You want to budget in the wind down time. You want to plan for that time. Your plane doesn't wait till it's over the airport to be like, oh shoot, I gotta land now. It knows when it needs to come in. So you got to plan for that. And actually wind down. Doesn't mean you have to turn off all screens and sit on the couch and meditate for an hour. Just don't do anything that you need to, that adds energy into the system. Dim your lights, slow stuff down. Watch shows you could turn off fine and not feel the need to watch the end of or whatever. Then when you're in bed, the number one tip I can give you in bed is get up. If you cannot sleep, get up. Don't make the bed be the place where you can't sleep. You will start training yourself to be awake in bed. It happens all the time. It's totally counterintuitive. And it's not about tonight. It's about rewriting this pattern. You don't want the bed to become the dentist chair, where as soon as you get in there, you start getting nervous and anxious and stressed, and which becomes a perpetuating cycle, because when sleep becomes predictably stressful, that stress becomes the very activation that keeps you awake. The stress about not sleeping becomes the not sleeping, which leads to stress about not sleeping. The only way to fix that is to break the cycle and get up. Maybe you're going to sleep less tonight, but the bed is going to be the place where you sleep, not the place where you lay there tossing and turning. If you're going to be all stressed and stuff, do it on the couch, be somewhere else. And then the third thing I'd say is when you wake up in the morning, just get up. You're not doing yourself any favors by lingering in bed. Get up, get moving, get light if you can into your eyes. That'll send a strong daytime signal, prime that circadian rhythm. Your sleep inertia, that fatigue you get when you wake up, will drop faster if you get up, get some light, get some movement, and you'll feel way better. Actually, it also actually works as an antidepressant. There's actually more than a dozen studies showing like getting bright light in the morning in your eyes, especially sunlight level light, might work about as well as a prescription antidepressant. So yeah, there's like a whole literature on this. A lot of people don't even know about it. That's where seasonal affective disorder came out of. It was used before seasonal affective disorder had a name, and it doesn't need to be seasonal for it to work. Because we spend so much time indoors, we might as well be winter all the time. So yeah, that's what I would say. Prep for it, plan for it, be ready to be, when you're in bed, be ready to be in bed. And when you're in bed, you can't sleep. Remember, sleep isn't something you do. Sleep is something that happens to you when the situation allows for it. And if you can control the situation to make it allow for it, great, do that. But if you can't control the situation to make it allow for it, and you're not going to be able to sleep, don't be in bed. And then when you do sleep, make sure you get up, especially at a regular time in the morning, get some light and movement, it'll set your day off right, and it will prep your body for sleep at the proper time.
I love that. That's a great idea. Okay, so we have a couple of more questions. Another congratulations on having the research results that prevents AHA to change from 7 to 8 essentials. That's fascinating and great. Appreciate
Yeah,
that.
I mean, I can't, and I have to say, it wasn't just me. I mean, I was one of the louder voices in AHA, and I think anyone in AHA will admit to that. But like, there's been others. So like when I first started AHA, people like Marie-Pierre Saint-Onge and Mercedes Carnathan, and some of those people had been laying that groundwork even before I got there. And so there's sleep in AHA is definitely growing. So it's not just me. But, you know, I was very lucky to be the one to help write that and make that case.
Great. Okay, so the next question is she has sleep apnea and I'm assuming a CPAP, and she tries her best to use it at night, but she has a really hard time falling asleep with it on, but she can fall asleep without it. So I'm assuming that's why some people maybe aren't using it and adhering. So how bad is it really for her to not use it? And I think you answered that, but
yeah. So okay, here's the thing. Some is better than none, probably. However, the typical medical model for when people don't use their CPAP machine is either you didn't hear me when I said it was important, so I'm going to say it louder in all capital letters and hope that you listen, or maybe you're just not motivated enough. Where as a behavioral specialist, I know that the world is way more complicated. There's all kinds of barriers. And if you're not able to overcome those barriers, you know, you're not going to win. So there's actually a whole literature on how to get people to use their CPAP in a way that works for them. And what I would suggest doing is find somebody who is, you know, at least a sleep specialist. Not all sleep specialists are good at this. Find a behavioral sleep specialist. So that website I talked to before is behavioralsleep.org. That's a society of behavioral sleep medicine. That's people like me who are behavior people, who work on reprogramming sleep patterns. And also there's a whole literature on how to get people to use their CPAP in a way that works for them, how to get them to acclimate to it, how to try new masks. There's more than 200 different masks on the market. If one of them isn't working for you, I bet there's another one that is. Also, maybe the pressure is wrong. If you're having, there's a sweet spot for pressure. If your pressure is too low or too high, it's not going to be comfortable. If it's too low, you still have too many events. If it's too high, you're blowing too hard of an air hose down your throat, and it's disrupting, and it's actually causing more problems. So that's just mechanical stuff. And then there's also helping people see their data, helping people rewrite the script, helping people reduce the anxiety, what happens when they wear it. Because if they wear it a bunch of times and then can't sleep and are stressed with it, every time you put it on, it's going to cause stress. You're going to have this Pavlovian response that's negative to this thing. So you're going to be aversively conditioned to it. We can reprogram that. So yeah, get help, because I have yet to see, in the 20 years I've been doing this, I have yet to find a mask problem that was unsolvable. It just sometimes takes time.
Excellent. Thank you. Okay, so the website again was behavioralsleep.org.
Yeah, that's the Society of Behavioral Sleep Medicine. That's our professional organization. There's also the American Academy of Sleep Medicine, which is the main sleep physician organization. I mean, there's other people in it too, but it's mostly sleep MDs. They mostly focus on apnea. And so that's like, these are people who went through medical school. So like, they're not as good on the behavior and insomnia stuff, but they're like the key sleep physicians in the team. And that's where you go to the sleep center to do the overnight sleep study. That's them. Behavioral sleep is more the psychologists and the behavioral people. Those are the two main clinical sleep organizations.
Great. So someone says, if you take a long time to actually fall asleep when you go to bed, is that a sign of not getting good sleep?
Well, so it depends. If you're laying there and are perfectly happy and it causes you no problems, I wouldn't worry about it. But if you're struggling, if that becomes a struggle, get up, wait until you're tired to go to bed, maybe delay your bedtime for a while. Whatever it is you're doing in bed, do that on the couch, any of that relaxing wind down, whatever it is you're doing, do it out of bed, because you don't want the bed to become the place that you can't sleep in. Younger people are usually fine with this, but then what happens, at some point they hit an age where, yeah, I used to be fine, I'll go to bed and I'd hang out there for a while, and then it would sort of blossom and become stress. And when it becomes stressful and frustrating, that's when you get up and get out.
So I have one more question, and then I have
Sure.
two others that I wanted to
Okay.
cover. One,
Okay.
is, so please explain as a summary of what to take away from the presentation for a person with type 2 diabetes who is 30.
First of all, something I didn't mention is when you go into diabetes clinics, there have been a couple studies that went into diabetes clinics and just tested everyone for sleep apnea. And there have been 3 to 5 studies that did it. The lowest rate of sleep apnea that was found in that diabetes clinic was like 65%. The highest was like 90%, depending on the clinic they went into. So for someone who has type 2 diabetes, chances are good that no matter what else you've got, you probably also have sleep apnea. And if not, you're at really high risk for having it. So keep an eye on that. People with type 2 diabetes also are more likely to have insomnia and struggling to sleep. So what I'm saying is, if you've got type 2 diabetes and you're 30, you might also have sleep issues that are treatable and fixable. And the younger you are, the easier they are to fix. And if you can do something now to either get better sleep, get more sleep, use your sleep to protect your metabolism. Because remember, sleep helps protect your metabolism and immune system. So if you've got type 2 diabetes when you're 30, you don't want it to get worse by the time you're 50 and 60 and 70. You don't want just plain old type 2 diabetes to be type 2 diabetes that's uncontrolled, that with neuropathy, with, and on top of heart disease and needing a bypass, and like, because you've already got a strike against you at that age, because it's kind of young for that. So there's a lot of time for new complications to arise. So you want to do whatever you can now. I mean, focus on your diet, focus on physical activity, and focus on sleep. Those are the 3 pillars of health. Trying to, neglecting any of those is trying to balance a stool of just 1 or 2 legs. They all support each other. Try and do what you can. And there's a lot that you can do. And sometimes sleep is actually the easiest thing to change and opens the door to changing those other things too, because if you sleep better, have more energy, you might be more likely to be active. You might be more clear-headed where you can actually eat better and not feel like you're craving that energy, for example.
Great. So the final question, and
Okay.
then I'll let everyone go.
Okay.
What is a good amount of sleep? And can the sleep be segmented? I know you said like nap.
Yeah.
Can
So
you,
the target you want to look for is 7 to 8 hours out of 24, but that's 7 to 8 hours by your recollection. Now, if you used a sleep tracker, it will probably register less sleep than you remember. That's fine. It's picking up all these micro awakenings that you don't even remember, that may not even matter. So if your tracker says 6.5 hours, but you think you slept 7, all of the guidelines, all of the AHA stuff, the data that was based on were these large population surveys that didn't have access to wearable data. All they had was self-report. So it's an imprecise measure. Yeah, it's a fuzzy measure. Yeah, it's a biased measure, but that's what predicts the outcomes. It's not the wearable data that predicts outcomes the same way. It would be great if we had a translator of the 6.5 on a wearable equals 7 by self-report. Like, we're not there yet. We don't know yet. Honestly, it's because the government hasn't spent the money to actually get wearable data on that many people yet. So we don't know. It's your own recollection of how much sleep you got. If you want to target 7 to 8 in 24 hours, it doesn't have to be all at once. First of all, the average person wakes up 10 to 20 times a night anyway. They just don't remember. That you wake up is actually not a problem. That the awakening becomes stressful is the problem. Some people have to sleep in 2 shifts. Some people sleep at night. They cannot get back to sleep, so then they take a morning nap for an hour or so. That's fine. College students are great nappers. And sometimes people like, we have this societal pressure to not nap, but that's societal, that's not biological. Humans figured out thousands of years ago that, a siesta in the middle of the day is actually great. It's good. The data shows it's good for productivity, it's good for fatigue, it might even be good for health. Sleep during the day actually counts toward the total, mostly. It's not one for one though. So like it might take 2 hours of sleep during the day to get an hour to an hour and a half's worth of sleep at night, because the sleep is a little more shallow during the day. Shift workers, any shift worker will tell you this. It's not the same, but yeah, sometimes people sleep in 2 segments at night. Some people they only get 5 or 6 hours at night, but then like they'll take a substantial nap during the day and they'll feel great. If you feel crappy after a nap, maybe you actually napped for too long and you got down into like too deep of a sleep. You actually want to cut the nap off before you get into really deep sleep sometimes. But yeah, so 7 to 8 hours out of 24. If you're younger, maybe edge toward 9. If you're older, don't worry about getting to 8. You're probably more resilient anyway. It doesn't need to be all at once. Don't stress about that. You woke up, you don't actually worry about. You actually woke up more than you even know. That the awakening happened, don't care. That the awakening was stressful, that it blossomed, that it was a problem. That's actually what we treat. We treat the problem, not the awakening itself. Same thing with hot flashes. So a lot of women will talk about hot flashes woke me up. Actually, it looks like if you look at the data, you look at the time course, the awakening precedes the hot flash. The hot flash didn't wake you up. You had it. This was one of your 10 to 20 awakenings that you had anyway, and your body's like, oh, you're awake now? Hot flash. Same thing with going to the bathroom during the night, where it looks like a lot of the time, it's not the bladder triggering the awakening. Most of the time, it's that you had an awakening anyway, and your brain's like, oh, you're awake, might as well go to the bathroom. And so as people get older, like actually that the awakening occurred was not the problem. It's that the awakening led to something disruptive was the problem. And that's what we try and fix.
Well, thank you so much. We really appreciate your time today. Thank you for everybody for joining us.
Thank you for having me.
The recording of the webinar will be up, and Dr. Grandner, again, thank you for the amazing work and for the opportunity.
Thank you so much. Take care.